So, thank you. Thank you for the organizers, for Yehuda Schoenfeld for this wonderful meeting. So, the title of the talk is High Levels of Memory B cells are associated with Abatacept efficacy in patients with rheumatoid arthritis. So, most of the job has been done by Pierre Gazot. So, we'll present his work. So, this is disclosure. So, some points regarding rheumatoid arthritis. As you know, it's the most important inflammatory rheumatism. It's predominantly in women. There's chronic pain and joint destructions. And there's guidelines to have a treatment as soon as possible, and the early phase of treatment is recommended. So usually we start with methotrexate, and after evaluations, if the treatment failed, we move to biologics, and sometimes we can move to a second or a third biologics. So biologics are growing, but really we need to improve the therapeutic strategy in rheumatoid arthritis to go to the first time to the good molecule. So for this purpose, we focus mainly in the functional significance of lymphocyte cell populations to try to see if this lymphocyte could help for therapeutic decisions. And for that, we use one molecule, which is abatacept, which is a fusion molecule with a receptor of CTLA4, which is linked with the Fc part of the immunoglobulins. This biologic binds to the molecules CD80 and CD86, which are present in monocytes, but also in memory B cells, and these molecules can cut the activations of T cells. So, what is the design of the study? So it's a retrospective study. There's 43 rheumatoid patients who received abatacept at the Brest University Medical School. They all followed the classification criteria for rheumatoid arthritis, and we select as control 49 patients with mechanical joint disease. So the phenotype include T cells, CD4 T cells, CD8, NK cells, and B cells with different markers, as you will see. So we have asked different questions. And the first one was, is there lymphocyte variations in patients with rheumatoid arthritis? So the expressions of the results is in absolute value. So there's no modifications when regarding all the lymphocytes, when regarding T4, CD8, and NK cells, and there's some reductions when regarding B cells. So we go on B cells and use two kinds of markers, IgD with CD38. We also used IgD with CD27, as the results are similar. We present only these ones. So with these two kinds of markers, you can distinguish naive B cells, activated mature B cells, and memory B cells. So what we have observed in our populations is that there's no difference when looking for naive B cells, mature B cells, but there's reductions when regarding memory B cells in patients with rheumatoid arthritis. So remains a target of abatacept is suspected to be present in these populations. So next question was related to abatacept. So we look at basal level and try to compare the level of lymphocytes to the response to abatacept. So patients were subdivided according to ACR-Euler criteria in good responders, moderate responders, and non-responders. So we look for different parameters, autoantibody, sex, tobacco, etc., and observed no association. It was the same for T cells, NK cells, and the only difference were again related to B cells. So we observe that total B cells, so CD19 B cells, were decreased, and this decrease was observed in patients with no response and also in patients with moderate response. And when we are looking for specific B cell subsets, the only populations which was reduced was, again, the populations of memory B cells in patients which were non-responders. So this was at basal levels. And now what is the effect of the abatacept on B cell subsets? So we are looking for different subtypes, so no modifications in T cells, NK cells, and for B cells. So patients were subdivided in non-responders, and as we have not information for all patients, responders, so good and moderate responders, were pulled together. So when regarding naive B cells, which are CD19, IgD, CD38 negative, there's no difference before and after abatacept treatment. It's the same for active B cells, and for the responders, what we observe is a reduction of the populations of memory B cells. So, as we have observed that there's big difference in memory B cells and in B cells, we try to use B cells and B cell count as prognosis factor. So, to establish this prognosis factor, as the selections of the populations who received abatacept was quite heterogeneous. Some of them received anti-TNF, others tocilizumab, and also rituximab. So for this analysis, we removed the 16 patients who have previously received rituximab to avoid misinterpretations. And for these populations, without patients receiving previously rituximab, we observe that an initial B lymphocyte, which was upper than 260, had a specificity here of 100 patients, quite good sensibility of more than 570% in all populations. So, in conclusion, from this work, we have established that the mechanism actions of abatacept in rheumatoid arthritis seems to rely mainly on the presence on memory B cells, and the initial B cell count is associated with the clinical response to abatacept. And in our cohort, we have observed that the initial B lymphocyte rate over 260 could predict the abatacept efficacy in patients which have not received rituximab. And just to remember you that all the other factors that we have tested, and we have tested a lot, were not associated with the response to abatacept. So thank you for your attention.